Hi everyone, so chapter 10 will cover management of pain and different types of techniques to manage the experience of pain. So the two types of pain are commonly referred to as acute and chronic pain. So acute pain results from a specific injury that produces tissue damage and disappears when the tissue is repaired. So acute pain is very short in duration, lasting for about 6 months or less. Chronic pain begins with an acute episode but does not decrease with treatment and the passage of time. The different kinds of chronic pain are chronic benign pain, recurrent acute pain, and chronic progressive pain. With chronic benign pain, this is pain that persists for 6 months or longer. It's relatively unresponsive to treatment, and the severity of pain varies. With recurrent acute pain, you have intermittent episodes of pain that are acute in character, but they're chronic in condition, and they reoccur for more than 6 months. Chronic progressive pain persists longer than 6 months, and the severity increases over time. So this pain is associated with malignancies or degenerative disorders. So there's common sources of chronic pain, which could be back pain, arthritis. It could be due to a nervous system issue, so something arising from the nerves originates in the nerves as opposed to muscle pain or bone pain. Psychogenic is having a psychological origin rather than physical, so mental illness or disorders could be a source of chronic pain. Studies have shown that depression and chronic pain are significantly linked. Others are headaches and pain that is occurring from cancer. Neurogenic pain results from damage to peripheral nerves or the central nervous system. Neuropathic pain is a type of neurogenic pain. It can happen if your nervous system is damaged or is not working properly. So you could feel pain from any various levels of the nervous system, but together the spinal cord and the brain are known as the central nervous system. And so damaged nerve fibers that send the wrong signals to pain centers can cause nerve function to change at the site of nerve damage, as well as areas in the central nervous system. Diabetes is responsible for about 30% of neuropathy cases. It's not always easy to tell the source of the neuropathic pain, but there are hundreds of diseases that are linked to this kind of pain. I have also incorporated a YouTube video that gives you a little bit more of a general overview about neuropathic pain and the types of treatments for it. So acute and chronic pain both have different psychological profiles. So with chronic pain, there's an overlay of psychological distress that often exacerbates and complicates the diagnosis and treatment. And so with patients with chronic pain, it's often wise to look at their psychological, social, and behavioral components of their pain. Oftentimes with pain, patients can develop maladaptive coping strategies, which often lead to poor health behaviors. And so chronic pain really requires this individualized treatment plan for clinical management. And so with chronic pain, it's important to assess the interaction between the physiological, psychological, social, and behavioral components. So all chronic pain was once acute pain, but there are several factors that can determine who makes the transition to chronic pain. So one is having a predisposition to react to a bodily insult with a specific response. So the behavior could be a tensing your jaw or altering your posture. And then on top of that, the pain can be exacerbated by stressful situations or even by efforts to suppress pain. And so rather than managing pain or dealing with it effectively, suppressing it can actually make it worse over time. Chronic pain patients can experience pain due to high sensitivity to noxious stimuli, having an impairment in their pain regulatory system, or an overlay of psychological distress. With chronic pain, that usually it requires an individualized treatment plan through a variety of methods and techniques that can be used by both patients themselves and by doctors. But sometimes doctors make mistakes and they can misdiagnose a patient. And so chronic pain can be exacerbated by a misdiagnosis and by giving the wrong prescriptions of medications or inappropriate treatments. So all of these factors can result in the transition from acute pain to chronic pain. Other factors that can result in chronic pain are chronic pain behaviors. So when somebody experiences pain, they oftentimes revert to coping strategies, which can maintain the pain experience. So for example, avoiding a loud noise or bright lights or reducing physical activity could actually cause the pain to continue and be maintained. So oftentimes when something causes pain, we try to avoid it, but in fact, this can actually make it worse over time. So these alterations in lifestyle become part of the pain problem, and they can persist and interfere with successful treatment. Sometimes it can also delay seeking treatment for pain. So once we determine certain behaviors in order to avoid pain, we sort of maintain the pain experience on our own, but it doesn't really get rid of the cause or the root of the problem. So we delay seeking treatment for the pain or managing it, and then over time, we end up avoiding situations that will interfere with that treatment, which can reduce quality of life for people with chronic pain. There's also some psychological disorders as well. There's studies showing that depression and pain are strongly linked together, and depression can increase perceptions of pain as well. So because chronic pain can disrupt a person's life, many chronic pain patients usually leave their jobs or they abandon certain activities, and so they develop a lifestyle that becomes centered around their pain. They can withdraw from friends and family, or they may even require public assistance. Pain can also result in the lack of sleep, and vice versa. Sleep loss can actually make pain worse, so it ends up being a vicious cycle. There's a loss of work-related aspirations and personal goals because life has now become dominated by chronic pain. And the loss of self-esteem that is experienced can be substantial. There's also compensation. So this can increase pain as it provides an incentive for being in pain. And so people that receive workers' compensation or they don't go back to work, they're more likely to avoid activities or work that would give them pain. And so it's almost providing a positive reinforcement for them. Chronic pain can take its toll on relationships, especially marriages and family. And so a lot of times chronic pain patients suffer in silence, or they may not communicate well with their family or partners, and so sexual relationships can deteriorate. There was a meta-analysis done of 103 pain experiences, and the study revealed that family and healthcare professionals a lot of times underestimate the patient's pain. They have a rough idea of what the patient's going through, but they don't fully understand the level and severity of it. And so a lot of it requires communication on the patient's part to communicate to their loved ones when they're feeling pain and how often and how much they're feeling pain. Among chronic pain patients whose spouses are supportive, it can backfire, or it can actually be a good thing, depending on the positive types of reinforcement. So what I mean is that when spouses are supportive, they could potentially do activities for the chronically ill patient that may serve as an avoidance factor. So caring for somebody with pain or not letting them do certain activities because they're afraid it may cause them pain serves as a positive source of reinforcement for the patient. And so they start to then rely on their spouse to do all of, any work that requires physical labor or physical activity. And so this can actually exacerbate the pain and maintain it over time. So positive attention from spouses may maintain the chronic pain. Nonetheless, as it does for many other negative experiences, having social support buffers the adverse effects of chronic pain. It, however, just depends on how the social support is being delivered. Some researchers have investigated a pain-prone personality, so looking at personality traits that may predispose somebody to experience chronic pain, and they found some personality attributes are associated with chronic pain, and those are neuroticism, introversion, and personalities that use passive coping strategies. And so because psychological factors are so clearly implicated in the experience of pain, the researchers hypothesize that there is a pain-prone personality. The problem is that the hypothesis is way too simplistic because pain itself can produce alterations in personality and behavior. And so the personality and behavior are consequences, not causes of the pain experience. So one thing that's been helpful for treating patients with chronic pain is to develop psychological pain profiles of different groups. And so researchers have drawn on personality instruments, and one is the MMPI. It's an instrument that's used to develop certain profiles of people that tend to exhibit symptoms of pain and feel pain. And so chronic pain patients have shown elevated scores on 3 MMPI subscales. And so these are hypochondriasis, hysteria, and depression. And so this constellation of traits is commonly referred to as the neurotic triad. And so these conditions can increase the perception of pain. So for example, depression reflects feelings of despair or hopelessness that can accompany long-term experiences with unsuccessfully treated pain. And so it increases perception of pain, which can feed back into the total pain experience. Depression can also increase the likelihood of pain behaviors, such as avoiding certain activities that one feels anxious to do because it might cause them pain. And so with interventions that are seeing a trend in depression with chronic pain, patients usually come in and the intervention usually addresses both the depression that they're feeling and the pain. Other types of conditions are anxiety disorders, substance use disorders, and other psychiatric problems that have shown to be linked with pain as well. And so because pain is significantly associated with other complicating disorders, it can be really hard to treat just solely on the basis of the pain experience without considering these psychological factors. Pain control refers to using techniques that result in either no longer feeling anything in an area that once hurt, feeling sensations but not pain, feeling pain but no longer concerned about it, or it could mean that the person is able to tolerate the pain that couldn't be tolerated before. So the most traditional and common method of controlling pain is through pharmacological control, and that is the administration of drugs to control pain. The most common and popular painkiller used is morphine, and it's highly effective, but it also can cause addiction. Patients can also build up a tolerance to it to where it no longer works. There's opioid medications that are widely prescribed for chronic pain, but they also do have the side effects of addiction, and then the effectiveness of it, as good as it is, can raise cautions about its widespread use. Local anesthetics are also used because they can affect the transmission of pain impulses from receptors to the spinal cord. There's also antidepressants. So these are drugs that act directly on higher brain regions. They combat pain not only by reducing anxiety and improving mood, but also by affecting the downward pathways from the brain that modulate pain. And then there's also nerve blocking agents. So that can be administered to reduce pain, but these also have a lot of side effects. They can cause limb paralysis and a loss of bladder control. Even when they're successful, the pain will usually return within a short period of time. Surgical treatment of pain involves disrupting the conduct of pain from the periphery to the spinal cord by either cutting or creating lesions in the pain fibers at various points in the body so that pain sensations can't be conducted. And so you're interrupting the flow of pain sensations from the spinal cord upward to the brain. Some drawbacks of this are that the effects can be temporary and it can be very expensive. The nervous system can potentially regenerate those pain pathways that were once blocked. And so pain impulses find their way to the brain via different neural pathways. And so even though you were blocking the pain at one point, it can often come back because the nervous system could have these substantial regenerative powers. And so therefore the surgery effects are short-lived. The other drawback is that surgery can damage the nervous system over time. And that worsens the issue. And so this damage can be another cause of chronic pain. And so it's pretty much causing another source of pain. Sensory control of pain involves counter-irritation, which means inhibiting pain in one part of your body by stimulating or mildly irritating another area. Typically, the counter-irritation produced will suppress pain to a certain extent. Then there's spinal cord stimulation, and so that is using a mild electrical stimulus that gets delivered to an area of the spine in order to inhibit pain. So you get a set of small electrodes, you place them or implant them near the point at which the nerve fibers from the painful area enter the spinal cord. And when the patient experiences the pain, he or she activates a radio signal which delivers that mild electrical stimulus to that area. So these sensory control techniques have had some success in reducing the experience of pain, but these effects are often temporary, and they may be appropriate primarily for providing temporary relief from acute pain, but not so much for chronic pain. Pain management experts have turned to exercise as a form of pain control by helping people increase their mobility to help their chronic pain. At one point, it was assumed that less activity contributed to better outcomes of pain, so that way pain could be healed, but now, as we do more research, we're finding that it's exactly the opposite philosophy. In fact, doing more exercise and engaging in more physical activity has actually helped improve chronic pain. And so as part of the treatment process, patients are urged to stay active in order to maintain their physical functioning. Biofeedback is another form of pain control, and it's a method of achieving control over a bodily process of which a patient is unaware of. And so typically biofeedback involves training somebody, is similar to operant conditioning. And it's where the person is getting biophysiological feedback on a machine about their bodily process that's typically associated with a tone or a sound in order to let the patient know what's going on inside their body. So for example, heart rate may be high, and so that might be converted into a tone so the patient can hear how quickly or slowly their heart is beating. And so once this function is tracked by a machine and providing feedback, the patient over time learns what thoughts or behaviors will modify that function and will attempt to change that bodily process through trial and error. And the trial and error is based on this continuous feedback from the machine. So biofeedback has been used to treat a number of chronic pain syndromes, and it's been shown to be successful in treating chronic pain. It's also, not only is it effective, but it's also less expensive compared to the other types of pain techniques and treatments out there. Relaxation techniques involve shifting the body into a state of low arousal by progressively relaxing different parts of the body using controlled breathing. So when controlled breathing is added, it's breathing shifting from relatively short, shallow breaths to deeper ones. So relaxation, meditation, slow breathing, and mindfulness, they can all reduce pain sensitivity and produce analgesic effects. And so a lot of times with relaxation techniques, a combination of different types of relaxation with self-regulation skills can reduce pain. And it can have beneficial physiological effects by releasing endogenous opioid mechanisms. Another mental strategy for controlling pain and discomfort is using distraction. So there's a lot of different distraction techniques. I'm going to mention 3 of them, but one is focusing on an irrelevant and attention-getting stimulus. Another is distracting yourself with a high level of activity. So let's say you're in pain, engaging in a high level of activity, maybe going to the gym to relieve some of that pain, or seeing a friend, or attending a concert. And then another one is focusing directly on the event, but reinterpreting its experience and the way you feel and perceive it. So for example, you may be faced with a very stressful event. And so one way of reducing the anxiety and pain is to focus on it, but maybe interpreting it as more of a challenge rather than as a negative event. Distraction can be effective for coping with low-level pain and acute pain. It's also most useful and effective when it's used in combo with other pain control techniques. Coping skills training can also help chronic pain patients manage their pain. They can either use avoidant or attentive strategies depending on how long patients have had their pain for. So there's some situations in which avoidant coping strategies works, and it seems to work for people that have recent onset pain. So in a study they did, which involved 30 chronic pain patients and 30 recent onset pain patients, researchers found that those with recent onset pain experienced less anxiety and depression and less pain when employing the avoidant coping strategy rather than attentional strategy. For people that had longer pain and they had chronic cases, attending directly to the pain rather than avoiding it was more adaptive than avoidant strategies. And so these studies suggest that patients might be trained in different coping strategies depending on the expected duration of their pain. Cognitive behavioral therapy is a technique that practitioners typically use to control people's chronic pain. Cognitive behavioral therapy entails reconceptualizing a problem from overwhelming to manageable. And so this is really based on how we respond to situations and our pain. So clients have to be convinced that they will master the skills they need to control the pain. and then they can reconceptualize their role in the management process. So a lot of this takes more self-control and self-efficacy. So in cognitive behavioral therapy, the goal is to promote self-efficacy in order to control pain through cognitive restructuring, such as reframing negative thoughts about the pain, and problem solving, such as defining pain-related problems and generating possible solutions. So this would entail monitoring and tracking your thoughts, feelings, and behaviors that seem to produce the pain you're experiencing. With cognitive behavioral therapy, people learn to break up maladaptive behavioral syndromes and make adaptive response to pain. They're also encouraged to attribute their success to their own efforts, are taught relapse prevention, and are trained to control their emotional responses. Pain management requires an interdisciplinary effort, bringing together neurological, cognitive, behavioral, and psychological expertise concerning pain. The first step is initial evaluation of the patient. And so typically a patient comes in and a therapist provides a qualitative and quantitative assessment of their pain. They also assess their function and they evaluate their psychological distress, illness, behaviors, and impairment. And then once that's done, they develop an individualized custom treatment that's tailored specifically to the patient's needs. So this includes creating specific goals for the patient to reduce the intensity of their pain. Other components involve providing the patient with sufficient education about what might be causing their pain and some ways that they can manage it at home. Also training them to reduce pain using relaxation strategies and gaining control of their emotional responses that might exacerbate the pain. Also, involvement of family has shown to be very effective, such as support from friends or family, encouragement on managing the pain, and also incorporating some relapse prevention techniques in the event that a patient relapses from pain. So the point of relapse prevention is so the patient can maintain post-treatment pain reduction.